Good afternoon. Welcome to the webinar on the longer run healthcare and health implications of COVID-19. My name is Martin Gaynor. I'm a professor of economics at Carnegie Mellon University in Pittsburgh, Pennsylvania, USA. And I'm joined here today by our panelists, Professor James Banks from the University of Manchester and Professor Carol Proper from Imperial College London. This webinar is brought to you by the Royal Economic Society, and many thanks to the Royal Economic Society for sponsoring this. James is going to talk about the longer run implications on health and the implications for the economy more generally about impacts of COVID-19 on health, and Carol will talk about healthcare. James, would you like to speak now?
Thanks, Marty. Okay. Let's see, here I come. Okay, great. Just put my screen up. Okay, hopefully everybody can see the slides. So thanks very much for inviting me to do this. As Marty said, Carol and I are going to sort of do a two-part presentation, which is really drawing on quite a few conversations that we've been having with colleagues of both of ours down at the Institute for Fiscal Studies in London. So really, I'm going to focus my remarks on the longer run health impacts of COVID. Of course, we know already that the number of deaths and the health impacts in the immediate COVID episode. I mean, here are some numbers that I just pulled off the ONS website on Tuesday, so the most up-to-date numbers on deaths. And what you can see for each of these age groups, the grey line is the the average number of deaths in the previous 5 years in this particular fortnight of the year so far, and the dotted lines are the minimum and the maximum, and the red lines are the number of deaths that we've had in the year to date. So you can see the excess deaths, if you like, predominantly focused in the 65s and overs, although also in the 45 and overs. This striking pattern, which is beginning to come down now, as of course we know. Don't be deceived by the small nature of the bottom red line, of course, for the 45 and overs. If you put these numbers into ratios, which can be expressed like a relative risk, for example, then you'll see that actually the relative risks are quite highly raised for the 45 and overs as well during the episode. The under 45s actually have not had mortality rates that deviate outside of the bounds of the maximum minimum in the previous 5 years. These are the numbers that we already know in terms of the mortality. I'm not really going to talk about that. As I said, I mean, there will be much more analysis coming through in the future on exactly how this mortality breaks down in terms of direct COVID deaths, indirect COVID deaths that may be related to healthcare issues or other issues. And of course, there's a lot of issues that need to play out in the analysis of that. We've had, some discussion of harvesting. Some of these deaths might be deaths that are slightly brought forward in time for vulnerable individuals that may have died in the near future. It's worth saying that some of the recent estimates of that harvesting effect are actually smaller, I think, than most people had expected. And of course, figuring out exactly what are the effects of COVID-19 is going to be quite complicated because the lockdown itself will have had some effects on mortality. And that's related to some of the things that I am going to talk about today. But really today I want to talk looking forward. So rather than analyzing what's happened in the past, I want to sort of think about more the medium, longer run prospects for health in the future. And this was a picture that was going around the Twitter sphere earlier on this year, which is quite nice, I think, and sort of expresses some of the ways in which the health pandemic might play out. And obviously we've had the first and in some sense the second wave of these two on this captured on this picture. But really what Carol and I are talking about are these third and fourth waves, the impact of interrupted care on chronic conditions, and ultimately the long run build-up of health issues that may persist into the medium and long run. And I think this is quite a nice way of thinking about things, and it sort of encapsulates the areas we are going to try and talk about. So when we're thinking about future health effects, we can think of essentially 4 areas which are going to matter. And primarily, of course, and we mustn't forget this, whether or not there is a second and subsequent waves of the virus, and if and when there is a vaccine, is obviously going to be a key issue in how all this plays out. I'm not really going to be talking about that today. It's not my area of expertise, but it's a crucial thing on which many things depend. Following down the chain, I think, one can think of the way in which distancing restrictions are lifted will well have health effects, as well as economic effects. And that lifting or otherwise of those restrictions is, of course, going to depend on the nature of the vaccine and the nature of second waves. But it's also going to depend on probably the government's views on the nature of recessions that may be resulting from those distancing restrictions. And that's exactly the third thing that one might want to think about when thinking about future health effects. So that's, there will be a recession, we know that. How long it will be and how deep it will be an issue. But there will also be an aftermath of that recession, and there'll be longer run consequences of the recession that we've had. And so really, when you're thinking about, I think, the future health effects, you want to be sort of identifying all those particular mechanisms. And it's worth saying that, of course, it's not just about mortality. Morbidity, the prevalence of disease and the number of people with certain conditions and the nature of risk factors is a key element of health as well, and we mustn't forget that. So let me just take a few of those issues in turn. Of course, there is a large literature on mortality in recessions themselves. As I say, my remarks are mainly going to be focused on the recessions element of the future trajectories. But of course, I'll refer to issues around distancing and the lockdown in passing. A number of people have pointed out, even within this episode, but certainly before, that within recessions, mortality may actually fall. And certainly there are examples of particular types of mortality and particular recessions where this has been the case. Lots of activity, economic activity may be associated with certain types of mortality, and if this activity is lower, then mortality will be lower as a result. But again, in distinguishing between during the recession and the aftermath of the recession, we also know that there are long-run consequences of recessions for those who are born in the recession itself. And I'll come back and talk a little bit about that in passing later on. If we want to think about morbidity, and that's the prevalence of disease as opposed to just mortality, there's a recent paper that I think it's worth talking about, not just because it was co-authored by my co-presenter Carol here, but did a sort of in-depth study of the last financial crisis in 2008 and looked at the effects of that financial crisis on 5 groups of chronic health conditions, in particular musculoskeletal, cardiovascular, respiratory, and mental, as well as other. And they really showed counter-cyclical relationships. So health in this disease sense, the morbidity sense, worsened in the recession, more so in poorer areas than in rich. And there were these important feedback and dynamic effects between areas. We've wrote a little piece about this, Carol I and Heidi Karolainen at IFS, our co-author, quantifying some of the effects of this. And their estimators suggest that a 1% fall in employment in the UK economy would lead to a 2% increase in the prevalence of chronic health conditions. And put differently, we've written here, roughly 1 million people or 900,000 more people with chronic conditions as a result of the employment fall that happened in the 12 months following the previous recession. Now, people are talking about employment numbers that are much larger than this at the moment. So that how that all plays out could be a very important factor. It's worth pointing out another important point of this study was to show that existing models of the way that economic conditions and health interact tend to underestimate the relationship between local area economic conditions and health. And this is another issue that I want to come back to towards the end of my remarks. But how useful is it to look at past recessions when we're thinking about the current recession? There's a number of things that I thought might be worth discussing under this context. First of all, I think, as always, and understandably, existing studies we have are typically of average effects. And they typically use fairly crude and broad health outcomes. So sometimes that's because if we're studying recessions that are a long way in the past, we don't have very good data. Sometimes it's because we're just using a particular object of interest, like self-reported health or whatever. But there are a number of aspects around health, naturally the number of conditions, the severity, what's called comorbidities. So if you have multiple conditions, then suddenly the health issues for that person and ultimately the treatment of that person can mount up. So there is a number of aspects of health, I think, in the more granular sense that aren't really captured from a simple understanding of the average effects of a past recession. There are other senses in which the current recession, of course, may be somewhat unique compared to the ones we've been experiencing in the past. There's been a discussion about we're all in it together, whether or not this means in terms of the effects of the virus or in fact the effects of the economic conditions. That was something to be discussed, and I will talk about that in a few minutes. There's another important sense which we're all in it together. When we're thinking of outcomes such as mental health, there's a literature and a debate in psychology about when an entire population goes through certain types of traumatic events. This is, I think, most evident in the war, that some of the kind of psychological measures of distress that you might expect to happen don't necessarily happen, because that sense of togetherness can counteract that to some extent. So there's many senses, and obviously the lockdown and the distancing that we're actually experiencing in the current recession, so the physical and the economic lockdown, will be unique to this recession. And so how that all plays out into future health trajectories in comparison to what we would have predicted based on future recessions, I think is an important question to understand. And it's worth to saying that even with those limitations, even historical recessions aren't the same as, they're different to each other. So even one forecasting from one to the next is a difficult problem. Here's an example. This shows you this chart here, which is taken from a recent piece of work at IFS a couple of years ago, compares the income losses during the recessions across the income distribution. So this chart shows that in the recession at the end of 1970s, the bottom third of the income distribution lost out the most, but in general, the income losses were across the whole of the income distribution up to the 90th percentile. If we now look at the 1980s recession, what we see is a rather different pattern, where actually the top half of the income distribution in that recession actually did not experience income losses. And now if we compare that to the great financial crisis recession in the UK in 2007, 8 and 2012, then we see a very different pattern of income gains and losses. And in particular, we see this point that in the recession, the most recent recession, the poor are actually relatively well protected. And this is a point that's been written about in a number of areas. And in fact, it's even been written about in the health inequalities literature. There was a recent paper by Eddie van Doorselaer and co-authors in the Journal of Health Economics that showed that the income inequality consequences of this recession were somewhat different than one might have feared if one had been studying past recessions, precisely for this point that the income policies, which are often supported by the state, kind of underpin some of the income losses that one might have expected. So even if one's thinking about the effect of recessions on health, not all recessions are the same in terms of who is gaining and who is losing. Which really brings me to the kind of point, I think, which is that I think if we really want to think through this, it's perhaps equally important, or maybe more important, to focus on thinking through the experience of specific groups and on specific risk factors and how they are changing, as well as, of course, putting that in the context of what we know from studying past economic fluctuations. So what do we know? Well, the first thing that we know is that currently in 2020, of course, the lockdown itself is affecting low earners, women, and young adults. So in some senses, we might expect this recession to look much more like the 1970s recessions that hit the poor than the 2008 recession that tended to hit the rich. The bottom chart here shows you the proportion of people who are working in sectors that are shut down across the income distribution, obviously much higher at the bottom. And the top chart here shows you that distribution by age. So obviously more young workers in shutdown sectors and more women in shutdown sectors. But of course, the sectors are being shut down, and then there are policies being put in place, such as the coronavirus retention scheme, to try and protect them. the workers in those sectors. So a key issue is going to be how well are those workers who are affected essentially by the shutdown, how are they going to be protected? And are those policies really going to work, and how long are those policies going to be in place for? Another thing we know, and this won't be a surprise, I suspect, to anybody on this call who knows presumably about the income gradient in health, is that the health vulnerabilities, which is the dark bars here, the fraction of people who have any conditions that make them vulnerable to COVID, or indeed have long-standing mental health conditions, is of course also higher in the lower income deciles. So one would think that, this is painting a picture of, low income, vulnerable health, potentially affected quite a lot by the economic conditions that are going to come along hand in hand with this pandemic. And I think that's largely going to be the case. I'm sure we'll talk more about it later on today. There are other types of groups that one might think of isolating for a particular discussion and interest. And the first one, I think, has to be younger cohorts. And at this point in time, I'm really meaning those, might think of in the early childhood development years. So let's say certainly in utero, babies, and early childhood. And of course, there's a strong and very convincing literature that shows that economic events and economic hardship in these early years has long shadows onto both health trajectories for these people in their future, and actually onto economic and demographic trajectories. The Gerard van den Berg study that I was talking about earlier sort of traced a large fraction of people through the Dutch population records, and showed that over the 19th century births in the Netherlands showed that those born in recession had a 5% shorter lifespan than those born outside of a recession. And of course, there are many other studies more at the microeconomic level that show life course effects, essentially early life disadvantage. The work of Janet Curry, many other co-authors and other authors in the area. So showing early life economic disadvantages having long health consequences. And we also know in a more causal way, I suppose, that certain interventions and policies aimed at the early childhood development years can be successful at improving health and other outcomes later in life. So in the UK, we had the Sure Start initiative, an intervention which was demonstrated to be extremely effective. So one thing for sure is that we know that those currently in the early childhood development years are very vulnerable to the economic fluctuations that their families are currently experiencing. One might think about how young do you have to be a younger cohort in this sense. So obviously there are large debates about those currently in school and university, and how they will be affected economically, and I'm absolutely sure that will be a key issue. How those effects and exposures might roll into future health is an interesting question. The literature on the causal effect of education on health is somewhat mixed. But I think one thing that we do know is that any mental health and psychological issues in adolescence and early adulthood are going to have very important implications for subsequent health and economic trajectories. So there's definitely a sense in which one might think of younger cohorts who are affected actually going much beyond the early childhood development age group.
Hi, James. You have another minute or two for your formal presentation. Thanks.
Okay. Well, I'll put up two pictures on mental health in that case. So the second group, very importantly to think about, will be those who've already got poor mental health. And we've already spoken about the fact that, of course, this mental health issue may play out slightly differently because of the fact that everybody is going through it. But there's some numbers emerging. This is numbers emerging from the ONS wellbeing study that show that in the March and April 2020, that the level of self-rated happiness is much lower than it was in the previous quarter of 2019. And there's also some interesting work, which I won't really discuss in detail, looking at loneliness and showing that the risk factors, this is a comparison of the risk factors for loneliness now versus the risk factors for loneliness in previous 2 years, and showing that the risk factors are the same, but the relative risks have been amplified. In particular, you can see that the young and the students and the low income have actually elevated risk factors of loneliness compared to the models in previous years. And the final third group that I'd like to think about in terms of identifying a particular mechanism would be when we have a shutdown or a pandemic that affects very specific areas of the economy, whether that's geographical areas or sectors. And I think there we know that there's a lot of literature on either long run or deep structural change that shows important health effects through to mortality or to chronic disease or to the so-called deaths of despair, the issues that Anne Case and Angus Deaton talk about in a lot of their work. So I think I'm going to leave that before my conclusion. So some behaviors, of course, are more complex. When incomes fall, some people, there's a lot in previous times, there have been less smoking and less drinking and sometimes even improved diet. So how that all plays out, how various other health risk factors like work patterns, occupational risks, travel and commuting behavior, how they look in the future are all also going to have permanent implications for health. So what do I conclude from this in the minute that I have remaining? Well, firstly, the effects are going to be complex. They're going to be different across the income and skills distribution, and there probably will be widening inequalities. And really, I think the important first lesson is to inform policy, we need to bring together an understanding of who's being affected both by the virus and by the lockdown, and then who is most vulnerable, as opposed to necessarily just generalizing from previous studies of economic shutdowns or recessions. I would worth saying that we won't really know more on this until the next couple of months when the COVID modules of the key longitudinal studies become available. These longitudinal studies will be able to look at individual levels of change between just before the episode and during. The second point of the three that I want to raise is that any strategic unwinding of the lockdown, which is now being talked about both in the economics literature and in policy, unwinding lockdown by industry, by area or age, it's going to have indirect consequences for health through its effects on the nature of the recession that we have, as well as any direct effects for health through virus exposure and transmission. And that's going to be a very hard set of issues to assess, but it's a very important set of issues to assess. And it's hard partly because of the lack of testing and high uncertainty that we have in order to design that lockdown, but the same uncertainty is going to translate into figuring out what the economic consequences would be. And the final point I have to make is that even without all these uncertainties around virus, these kind of issues, the policy making, when you're trying to have hard to quantify long run costs in terms of the health of future generations against rather salient short run political issues, whether that's spending, taxes or benefits, these are particularly challenging issues for policymakers anyway. It's the same kind of set of issues that means that a sort of rate of return on investment or a cost benefit analysis is really insufficient to kind of provide the evidence that governments need. You really need leadership and ethical judgments to essentially value the gains in the future, the losses today in different dimensions, whether these environmental or intergenerational. And I think it's a very big challenge essentially to try and build some of these understandings of future health effects into policy. And indeed, I would probably just finish by saying that the way in which different groups are represented in the policy-making process, the way in which the large companies, small companies, young workers, older workers, different regions are represented in the policy-making process is a key part of how all that policy-making procedure can actually play. Okay, so I think I'll finish that there and then maybe we'll come back and talk some more questions later.
Thanks very much, James. I'm going to turn things over to Carol Proper now, but while Carol's getting ready, let me tell people, if you didn't notice already, you open your chat window, there's an email address to which you can direct questions, webinar@res.org.uk. So if you have questions for James or Carol, or just things you'd like addressed generally, please send them to that email address and we will receive them. Thank you. Carol, please.
Thank you, Marty. Thank you very much, James. So as James said, I'm going to talk, I hope you can see my screen, and I'm going to talk about the impact of COVID-19 on the NHS and healthcare. So like James, I'm not really going to reflect very much on the current position with who's being treated for COVID, but my starting place is that preventing the NHS being overwhelmed was at the forefront of policies to deal with COVID-19. And this led to a dramatic reorganization of NHS facilities to deal with the pandemic. Approximately 30% of the 100 or 1,000 beds were shifted to COVID patients within the NHS. We also saw big attempts to bring on more labour force, so there was accelerated graduation of some nurses this year, and also the call for retired NHS workers to come back and help with COVID. To try and alleviate the pressure on the NHS, very much driven by fears of what had happened in Italy, which is a very well-resourced healthcare system, there was the cancellation of all non-urgent care and early discharge of other patients. So that took place, all of that, against a backdrop of existing staff shortages. So over the last decade, although staff numbers have gone up, it's pretty clear most analysts in the healthcare space think the demand for care has grown more rapidly than that increase in staff numbers. So we're already in a deficit position. And we know that there were some estimates last year and some nice work by the Health Foundation that showed that we have an estimated 40 to 50,000 shortage of nurses before we even entered the pandemic. So I think against that backdrop, what I'm going to do is ask, what will be the impact on the supply and demand for NHS care of COVID? So let me go down. Sorry, I've gone down too many. So I'm going to start with supply side issues. So I think clearly staff shortages are likely to continue. Partly we've already got this shortage of staff, but I think COVID itself will cause problems. Clearly the issues around personal protective equipment, whatever the health minister has said, have been very worrying for the service, not only health service, but also for social care workers. And I think concerns over safety of staff may lead more people after this huge effort that they've done within the NHS to early retirement, and possibly less decisions of British-based individuals to become, for example, nurses. But more broadly, particularly in the nursing labour market, we need to remember that the NHS competes in a worldwide labour market in which there is already a nursing shortage worldwide. We already had Brexit concerns. I think Brexit is going to cause problems for our recruitment from the EU. I think our performance, the performance of the NHS and the performance of Britain with respect to COVID, particularly with respect to several European countries, even small European countries who spend perhaps as much as we do on healthcare, like the Slovak Republic or the Czech Republic, those countries have dealt with COVID better for all sorts of reasons. And I think healthcare workers are going to think twice about coming to Britain when they could work in their own countries. We know from the economics literature that both staff shortages and the kind of team disruptions that occur with staff shortages and staff replacements have been shown to result in lower quality of care within the healthcare sector and indeed longer waiting times, both of those bad outcomes. In response, I think, to the supply side issues is we are likely to see upward pay pressure for individuals within the NHS. That indeed, so the NHS, as many people listening will know, has a national regulation of wages to try and encourage same wages with a bit of adjustment for local labour markets for the same job. What this means is that in areas for which are high cost to live in, particularly for nurses who aren't that well paid, there's a bigger shortage already in high cost areas. I think this is going to lead to pressure to relax wage regulation within the NHS. Now you could say you could pay more for nurses in the London and South East, which have big shortages, and pay less in areas like the Northeast, where a nurse's wage goes further because living costs are lower. But I think areas like the Northeast are going to be very hit by the economic impact of COVID, and therefore lowering the wages of people in the public sector is not going to be an attractive political or social thing to do. So I think there's going to be pressure on wage regulation and upward pressure generally on wages. On the good side, we might see from the supply side that production methods may change. We may, for example, accelerate the shift towards digital healthcare, and we've already seen GPs and, for example, cancer oncologists and others consulting with their patients on Zoom or telephones or other ways. Now, there's clearly some demand for that. Not all patients will want that, but I think COVID will accelerate that as it does in the rest of the economy. All of those things I think are good. So now I want to turn to the demand side issues. So we enter the post-COVID world, or the months going ahead, it's not yet post-COVID obviously, but the first wave of COVID, with a large backlog of unmet need. First of all, there's a backlog of elective procedures. Now, elective procedures don't just mean things that historically have had long waiting lists, but also mean things like treatment for cancer and diagnostic for cancer. All those services have been delayed, deferred, or in some cases, cancelled temporarily. So there's this backlog of cases. On top of that, I think we've seen an interesting behavioural response. We know that there's been almost a 50% drop in A&E attendances by individuals, and also a drop of some GP visits. Now, that may be good in some cases. For a long time, the NHS has been urging people not to use A&E as a GP surgery and instead use GPs. But it's very clear from what the British Heart Foundation and others have said, that some of the people who aren't turning up at A&E are people having strokes or minor heart attacks. Therefore, there's this stock of ill health that's building up where they should have got treatment, but stayed away and didn't get treatment because they were fearful or they didn't know whether there'd be capacity. So I think that's going to increase the severity for some patients, including, for example, cancer patients. Now, we currently don't have any idea of who it is that's going to have the increase in, or the extent of that increase in severity. That will become apparent in the next few months as normal services are partly resumed. We will also obviously see an increasing time for the waiting times for the common electives such as hip replacements, knee replacements, cataracts, which occupy about a large proportion of the NHS elective budget. This will result in increased suffering for those who are waiting, and may indeed, there's some economic research to suggest that higher waiting times result in higher mortality. So against that backdrop of this build-up in demand, I'd like to focus on who it is that is likely to be affected by the shortage of supply. So first of all, I want to turn to age, and this is a picture of the age distribution of emergency and elective cases in normal times. So this is taken, thanks to my friends, to my colleagues, George Stoy and Ben Zaranko at IFS, by analysis of emergency and elective admissions within the NHS between 2017 and 2019. So kind of averaged over the recent years. And this shows, sorry, I'm on the wrong slide. This is age. This shows along the bottom axis age and its rates per age group, and it shows in blue the elective admissions and in orange the emergency admissions. If we turn first to emergencies, we can see that there is quite a high rate of emergencies within the under 10s. That's normal, that children can become very ill very quickly and need taking to A&E. But then it drops off, and in fact, there's a pretty clear gradient across all age groups, with emergency admissions rising until almost the very oldest group, and then falling in the 90s, probably because a large number of those individuals are in care homes where people come to them. If we look now at electives in the blue, it's very clear that the largest group of elective users relative to the population are those in their 40s, 50s, 60s, and 70s. So the reductions in non-COVID emergency and elective care will disproportionately affect, in some, the over 50s. If we now look at the deprivation distribution of the same emergency and elective admissions, this graph shows the least deprived areas on the in deciles on the left-hand side and the most deprived on the right-hand side. There's less of a gradient in electives. The use of electives across deprivation deciles is pretty constant. But there's a clear gradient in emergency admissions by deprivation. Those people who live in the most deprived areas of Britain use emergency services more. And finally, by ethnicity, and I refer to this because of all the issues around deaths, excess deaths in these groups from COVID, the picture there is more mixed, but there is higher use relative to the population by certain ethnic groups of NHS, particularly, for example, Black Caribbean, people of Black Caribbean heritage. So in the near future, i.e. the coming year, I'm thinking, the most deprived and the oldest individuals are likely to have been hit by COVID, reducing services, and will continue to be hit by the disruptions that COVID has caused to the service. So now I want to turn on to longer term health impacts. So as James has already talked about, there are knock-on effects from the economic recession. And I want to highlight three of those or draw them out. He's already talked about them. The first is the rise in mental ill health. The second is the rise in chronic illnesses that will occur. I think both of those are pretty sure to happen. My own work with my colleagues showed a rise in chronic illnesses. It's well established, the literature on recessions, though mixed on some of the impacts of recessions, perhaps the only one finding that's pretty clear from that literature is regardless of the recession, regardless of the country, there appears to be a rise in mental ill health after recessions. Quite how the nature of the lockdown will affect that in the short run, I think, is a little different. But in the long run, I think any impact of any recession is going to hit mental health. And nobody is immune from mental health problems. These are already vulnerable groups. And I think it's worth saying they are also areas where NHS and other services are already limited. For example, we have clear evidence that child mental health services are woefully underfunded in the UK. And generally, services for the chronically ill, as opposed to hospital services, tend to be underfunded as well. So these are areas where there is going to be rising need, and there is already a shortage of provision. I think the overall implications of that are that reduced access to NHS services has the potential to increase health inequalities, because those who use services most and are going to be most affected by the delay and the cutback in services are the least healthy. I also think that the full effect will take time to manifest itself. The NHS runs very close to capacity all the time. And as I've pointed out, it's somewhat under-resourced, at least in terms of staff time, in terms of capacity anyway. So I think there's going to be quite a long-run effect of the effect that you've taken out all these resources to deal with COVID against a backdrop of a shortage of resources. So, coming to my conclusions, what do I think once I've done that rather rapid overview, if you like, of the pressures on both the supply and the demand side for the NHS? So I think the first conclusion I come to is there is going to be greater pressure for increased spending on the NHS from both the supply and the demand side. So there's a supply shortage I think we're going to see staff moving out of the NHS. I think we're going to have bigger recruitment problems. That means that we're going to have a supply shortage. The way to address a supply shortage is to pay more in the short term and probably in the long term as well. On the demand side, we have a pent-up demand, which is going to affect primarily the old, and we know that the old are more likely to vote than the young. So I think this is going to lead to pressure from the demand side for greater resources to be spent on the NHS. And that's going to be compounded by the fact that it's pretty clear that our underfunded social care sector has not been able to perform well during the COVID crisis. I think it will also lead to the possible need to change the balance of services which are funded, as well as raise funds for an increase in expenditure. So I think this will prompt both reorganization, which is already going on, but more generally, a good look at which services you want to fund. More worryingly, I think, at least for those who believe that the NHS should be the only provider of care, is that I think there will be a possible increase in demand for and the supply of private care. We know from past research that private health insurance demand is very responsive to the length of waiting lists. Waiting lists are going to rise. It also depends on being able to have the income from it. And I think the nature of this recession is clearly at the moment hitting the incomes of the most vulnerable and hitting the incomes of richer individuals less. Now that may change as returns to capital change, but if it doesn't change, then individuals who can do well in the lockdown by working at home and being paid are going to think about perhaps using that income to demand private healthcare insurance. On the supply side, I think we're going to see the exit of some consultants from full-time and part-time NHS work. And I think there is a supply of consultants willing to work in the private sector. I think that's likely to expand as the result of how some medical professionals have felt they have been treated during COVID-19. Despite their best efforts, they have not felt that the government has been on their side. That may or may not be right, but that's a feeling, and I think that will drive their decisions. The final thing to say is that the private sector has capacity. At the moment, some of that capacity is being used to help treat COVID or treat the overspill from COVID. When that stops, the private sector is going to be left with that capacity and will be left with a willingness to fill those beds and fill those slots. So I think we're going to see an increased demand for and supply of private care. In conclusion, I think all these changes have implications for inequalities in healthcare and who gets it and where they get it from, and in health, as James has said. And I think we need to remember that I think COVID-19 has exposed inequalities which already existed, including large health inequalities in Britain, larger than, for example, in France or some other comparable large economies. And so that the policies needed to address both the NHS and more generally the landscape of healthcare provision and funding are going to operate in an environment of greater need, greater demand, and greater inequality. Thank you for that. And I will now stop screen sharing.
Thank you so much, Carol, and thank you, James, as well. Wonderful presentations. I've been asked to say a few words about the U.S. situation, which I will do. The biggest difference between the two big differences between the UK and the US. The one that's very obvious is the role of private financing of care, which is a major source of financing in the United States. More than 50% of all care in the US is privately financed. And the other different starting points for the US healthcare system and for the UK. So in the US, there are going to be effects on both demand and supply, as one would expect. As everyone knows, there's been a lot of both job loss and job insecurity, and that will have impacts on demand for healthcare through two venues. One is the fact that people have health insurance, private health insurance, in which there's substantial cost sharing. They have to pay quite a bit of the expenses out of their own pocket. Deductibles for private health insurance, $500, $1,000, $2,000, in some cases $5,000, which is a substantial amount for many people. The other is that a number of people will have lost their health insurance by virtue of having lost their jobs and may not be able to readily replace that, either through the Affordable Care Act, private health insurance exchanges, or through Medicaid enrollment. States are under tremendous fiscal pressure at the same time, and there are certainly going to be cutbacks to public financing through the US states of health insurance. So we have those impacts. Almost certainly reduction in demand, reduction in quantity. There may be impacts on health. It's not so clear exactly what the medium to longer term impacts on health will be. On the supply side, again, focusing on private, which is almost all of the US healthcare system is privately delivered. And we're going to see, I think, quite a bit of exits. Smaller hospitals are often in rather weak financial condition. For many of them, this will push them over the edge. Physician practices, often, again, the smaller ones are not in particularly strong financial positions. There will be some exit, consolidation. Some folks in the US said it's going to be a buyer's market for large, well-financed healthcare systems, which of course are taking a hit but have substantial reserves. You may be talking about millions or even $1 billion or dollars or more in terms of cash reserves on hand by these entities. One other thing that's happening that I think Carol noted is there is some loosening of regulatory restrictions on supply, broadening of telehealth and particularly paying for telehealth, loosening of restrictions on what nurse practitioners and pharmacists can do. So those may offset to some extent some of the impacts on supply. So in sum, what can we expect to see? I think we can expect to see reduced access to care in places that already didn't have particularly good access to care, rural communities or low-income communities in large urban areas. I think there'll be less access than there was previously, which will only exacerbate inequalities that are a result of the system. There will probably be substantial upward pressure on prices. Now, because we'll probably have non-trivial reductions in demand, it's hard to say how all of that will play out. But I think that given what we see on the supply side, that will have larger, higher prices or less of a reduction in prices. We end up with reductions than we otherwise would have. Quality of care may suffer as a result. It seems unlikely we'll see any major organizational or institutional innovation forthcoming in the medium to longer term. And on the politics side, there are a lot of issues with regards to high prices, rapidly rising prices, abusive pricing practices in the US system. And I doubt there's going to be much appetite among politicians for taking those things on in the aftermath of COVID. And I think that will be not just short term, but actually longer term impacts. Another thing that's been happening in the US system that apparently is in contrast to the UK is there's been a big increase in unemployment in the healthcare sector itself. Quite a few healthcare workers, including nurses, have been laid off. And so I think if we see demand slow to pick up, we can expect that continue. We can expect to see downward pressure on wages rather than upward pressure. If we have further consolidation, we may have either new monopsony power or an increase in monopsony power, which could push wages down further. So there, I think that's an issue, and because healthcare is 1/5 of the U.S. economy, and the largest employer in many states in the union, then I think that will have profound impacts on employment writ large in the U.S. as well as obviously the economy as a whole. Healthcare spending will undoubtedly pick up a bit. It's down a lot right now, but longer term, will it get back to where it was? I don't think probably for quite a while. I think we'll see some slower growth, and that this is all a very interesting question because economists, myself included, for many years now have been decrying not just the high level of healthcare spending, but particularly the rate of growth. Well, now we have that, but obviously not for the reasons that anyone would have espouse, but because of this terrible disease that is wreaking havoc on our societies. But I think we'll be looking at this overall impacts on healthcare spending, reducing it, and the impacts overall on the economy for quite some time. So I'm going to conclude now. I'm going to ask Carol and James to come back and join me, and we can have a discussion. There were a couple questions that got submitted. Hi, James. Hi, Carol. Welcome back. Let me give you a couple questions that came in from folks. One, the question is the following: was it optimal to have the Great Lockdown, taking into account quality concerns, if you like?
Shall I? I mean, my answer is we had no option except to lock down. We locked down so late that when we saw what happened initially, where the Lombardy region has a very well-resourced healthcare system, a better resourced healthcare system than the NHS, and the Lombardy region was struggling. We had no option but to lock down. The issue about when to take off the lockdown, I think, is a very live one. And obviously, we're now moving into that phase. But the initial response was the correct one.
Thanks.
I think, yeah, I think that's absolutely right. And I think the issue really is what was the counterfactual. There's I think there are some views out there that somehow if we hadn't had a lockdown, the economy would have just carried on and we would have had a bunch of sick people. Not the case at all. In fact, many economists have pointed out that, lots of economic activity will be incredibly affected even without the lockdown, and then probably, and actually that was an issue really when a lot of economists were saying you don't want to lift it too early because the economic consequences of an early lockdown lift and all the economic chaos and the sort of the informal way that the economy would return to its active state would be potentially worse than some kind of managed and strategic exit from the lockdown. So I think that's absolutely right. I think and I think the issue of the counterfactual is really clear there. It's very important to bear in mind.
Right, thanks. And I'll agree with that in the U.S. context as well. In the absence of testing, even the availability of tests, let alone the organization to implement those tests and use them effectively, or any other kinds of protective measures, let alone treatment, and of course a vaccine is far off, if at all, then there really weren't any other good options. And it's not just a public health matter, it was an economic, and is an economic matter as well. We have another question. This was directed at James, although Carol, you should feel free to chime in if you wish. Will the impacts of redistribution of COVID-19 recession be more like that of the 2008 financial crisis or that of the 1990s?
That's a really interesting question. I think certainly the key issue is how are the policies that we're putting in place going to play out? I think if you look at the distribution of the underlying shocks before the policies start intervening to ensure those shocks, it's much more of a recession that looks like it's going to be hitting the more vulnerable and the poorer households worse. So more like the recessions of the 70s and 80s. And which is a bit unfortunate because, of course, the recession that we've studied the most, partly because we've got the best data on health and partly because we've got the best data in general, is the more recent recession, which had a very different pattern. But as I said, I think the key issue is how are all the various policies that we're putting in place now, whether they're the small business schemes, the job retention schemes, or anything that we might be putting in for young mothers and childcare and everything else, how are they going to work? I think that's going to be the key issue in how this ultimately how this recession plays out, is how successful those policies are going to be. And actually, if you think about the public economics or the public macroeconomics, how are we going to finance those policies? How are we, and so the ultimate distributional effects, I think, are really going to remain to be seen, because the effects of those policies is as yet unknown, and the way in which we finance them is as yet unknown. And I think those are going to be the key determining factors. But there's no doubt, I think, in my mind, that the underlying shocks that the economy is faced with are sort of more like the way that Carol was speaking. They're amplifying the existing inequalities in the way that, sort of poorer households were affected by the earlier recessions, as opposed to the great financial crisis.
Thanks. So let me throw a question out there to both of you that sort of builds off that. A number of folks have been hypothesizing that the pandemic is a wake-up call to the UK, to the US, to every country, and that in the wake of this, that we'll do things differently. People are thinking in a better way, and in particular with regard to health and healthcare, that will come out the other side, and this will have cast light on all the deficiencies, as both of you have so eloquently illustrated, but that our countries will undertake the changes that are necessary to address those issues. What do you think about that? Do you think it's likely that the light the pandemic has cast on the issues in the UK will be addressed? Or do you think that actually it will end up making things worse, not better?
I'll answer that very briefly because we don't have much time. I think the whole of this hinges on the politics. If the political will is there for that, and the political will is there to fund that, I think it might. My worry actually is particularly for the NHS and the social care sector, that they will simply return to their business as usual with the models that I currently think they have that have many deficiencies, particularly running the NHS on such tight capacity. But that's about how much money we are willing to spend for those areas and what we're going to do about social care.
Yeah, I'd be very brief as well. I'd agree with that. I think that the politics of how this plays out in terms of which groups are represented, whether this is the sort of big business, small business, whether it's the younger generations versus the old, how there's a whole bunch of issues that will determine, I think, how we come out the other side of this. I'm sure that there's some social behaviors and some demographic and residential behaviors will be affected for some time. And certainly that's the lesson that we understood from the previous RES webinar looking at previous pandemics. I mean, we can expect long run effects on the way in which we think about cities, the way we think about travel, the way we think about family behaviors, I'm sure. The question is, how does that turn into policy?
Mm-hmm. Right. And again, I'll echo this. I think my fear is that in the US context, that some of the existing problems that we had in the system have exacerbated and may very well get baked in for the long term, that there will not be the political appetite or will to deal with these sorts of things. Here's a question that just came in, directed at James, and we've got about 60 seconds. How well do we understand the health effects that are not entirely mediated through income, e.g. the effect of being unemployed or forced to work in a job for which you are not qualified after controlling for income? So if you could answer that, very thoroughly in about 15 or 20 seconds.
I would say not as well as we would like. In general, I think we have a lot of quasi-experimental studies, some of which reveal mechanisms, but as always, I think the more we can get to the mechanisms and the specific risk factors, the more that will inform us. And I would always like to see more in that dimension.
Thanks very much. Well, let me again thank the Royal Economic Society for putting on this webinar on a very important topic and in a very timely way, and thank James and Carol for their expert and concise assessments of this. And it's really important to be looking forward. We're obviously grappling with what's happening right now, and that's critical, but we do need to be thinking about longer term impacts and planning for that. And I think RES and James and Carol are doing a great service to society by giving over thoughts on this and shifting some focus to that. So, and thanks everyone for attending and for the great questions.